Thank you, sir. So this is about the lateral rectus anchoring to the lateral periosteal, lateral wall periosteum. And again, we are using the limbal approach for this because that's the best way to see the lateral side. We are opening up the conjunctiva, and we are the conventional way. So we have made the opening, we've opened it on the side. The lateral rectus will be disinserted and passed on sutures in the same way. However, the difference would be that we would prefer to use ethibond or a non-absorbable suture for this. This helps to make this procedure a little reversible also. So as we would do, we have passed the sutures through the lateral rectus and we have disinserted. Now we are going on to the lateral orbital wall, and we are going outside the cone. So we have to open the cone and the structures that are between the muscle and the lateral orbital wall. So we are going straight down towards the lateral orbital wall periosteum, and with sharp dissection and a little bit of blunt opening, you can go right up to the lateral periosteum. You have to feel it before you start passing sutures. The trick to pass sutures here is you have to bend the needle a little more so that you can roll your hand and pass it more easily. You have to check when you are passing and tying the sutures, you have to check them before you start tying them so that they do not cut through. So it's important that when you are passing and tying them, you can see the white periosteum whenever you are passing the sutures and tying them. The other important thing to do is to identify the tenons that you had opened up so that you can close it back again. You can see the muscle that is tied there, and over that you are going to close it so that it becomes, as Sir said, sequestered outside the muscle cone and the tissue planes so that it cannot get back attached to the globe, to the sclera, and the raw end is stuck onto the periosteum. So you have to carefully close it over it, and also do a force duction test to make sure that it is free. So you just identify the muscle there posteriorly, and then the conjunctiva is closed as it conventionally will be for a limbal opening. As Sir has pointed out, the challenge is the anomalous innervation to the lateral rectus, and it is sometimes very difficult to recess it very far back. Hangback is an option, but there is always the chance that the muscle can creep forward and get restuck. So persistence or recurrence of misinnervation even after large LR recessions are there, and that is why this procedure. It is reversible. It permanently disinserts the muscle from the globe, preventing recurrence or the effect of miswiring being visible. There is less risk of globe perforation when you're passing it very far back into the sclera. You do get very good alignment and prevention of muscle attachment to the globe as it is possible in a free tenectomy or myectomy. So Sir has shown some photographs. I'm just showing you. You can see the important thing is to look at this this severe retraction that you are looking at when the patient sees on the for dextroversion. So you can see the left eye has gone so far up that it is not even seen in the palpebral fissure. So for this, it's a very good procedure. You can see that almost completely the miswiring has gone, and you have very good alignment in primary gaze. So again, this is a very good procedure for exoduance. Another left exoduance, you can see the retraction that is visible in dextroversion, and you can see that there is very good alignment as well as the elimination of the narrowing of the palpebral fissure, the retraction and the shoots in adduction.